This is Dr. J.B. Kanwar. I am working as a professor in the Department of Endocrinology in IMS and SOM Hospital, Bhubaneswar. Today, I am going to give a case scenario where there is implications of Empalina combination. So I would start with my case. This is a 58 years old male. He is diabetic for last 18 years. Along with diabetes, he has a few comorbid conditions like he is hypertensive and also dyslipidemic. And he is on insulin for last 6 years. And to be very specific regarding the insulin dose, he has been on regular insulin in the morning about 28 unit and 24 unit regular insulin before lunch and 20 unit regular insulin before dinner, as well as he is on insulin glargine, which is a basal insulin which he takes about 10 p.m., about 30 unit of basal insulin he takes. So overall, he takes about 100 unit of insulin per day. And he's also on vildagliptin and metformin combination, 5,500 milligram twice daily. So these are the anti-diabetic medication he is on. And he has been on insulin for last 6 years, and because of poor glycemic control, his insulin being increased every time he visits the doctor. So at the end, the time he met me, see, he is on about 100 unit of insulin. Still, the blood sugars were uncontrolled. I will speak about that blood sugar, but along with this anti-diabetic medication, he is also hypertensive and is on telmisartan 80 milligram once daily, as well as amlodipine 10 milligram once daily and metoprolol 50 milligram once daily. As I mentioned, he is also dyslipidemic, so he has been on rosuvastatin 10 milligram once daily. So this is a typical kind of patient, long-term diabetic patient, along with hypertension and dyslipidemia and on multiple medications. On examination, his body weight is about 84 kg with BMI of 30 kg per meter square. And what is important is that after starting insulin during last 6 years, he has gained about 10 to 12 kg, and mostly he has gained about 8 kgs during last 2 years. And his blood pressure has been mostly uncontrolled. The time I looked at him, the blood pressure was 150 by 92 millimeter mercury in right arm position. And rest of the systemic examination were normal. His cardiovascular and respiratory system examination were normal. And on investigation, I'll speak about some of the relevant investigation related to diabetes. His fasting blood sugar and postprandial blood sugar were fairly uncontrolled, with fasting blood sugar of 157 milligram per deciliter, and 2-hour postprandial blood sugar was about 278 milligram per deciliter, and his HbA1c is very poorly controlled, with it was about 8.8%. So a diabetic of 20 years and on insulin for 6 years and on about 100 unit of insulin per day, and with patients of obesity, hypertension, dyslipidemia, is having very poorly controlled fasting and 2-hour postprandial blood sugar. And further investigations like urea and creatine has been raised, with urea of 50 milligram per deciliter and creatinine of 1.6 milligram per deciliter. And his eGFR was 62 milliliter per minute per 1.73 meter square. And however, his lipid profiles has been well controlled with the rosuvastatin LDL of 88 milligram per deciliter, and his SGOT and SGPT were mildly increased. SGOT was in the range of F68 IU per liter, and SGPT was 76 IU per liter. So, just to summarize, this patient of 58 years old, diabetic for 18 years, and is 58 years old patient, diabetic for 20 years, and has been on insulin and oral anti-diabetic agent with 100 unit of insulin per day with oral anti-diabetic agents and multiple anti-hypertensive, and on statins his sugars were uncontrolled, and also he's an obese patient. So regarding the treatment aspect, what do you want to do? What are your goals while treating this patient? So the first goal is to achieve the blood sugar control, achieve the target HbA1c of less than 7%. And then other targets like we should reduce the weight, at least to keep the body weight normal. He was increasing, he was having increasing in body weight for about 8 kgs during last 2 years. And the third goal is to achieve the target blood pressure goal, either to by adjusting the antihypertensive or maybe some of the anti-diabetic like SGLT2 inhibitor are good in also reducing the systolic blood pressure. Empagliflozin or SGLT2 inhibitor, as far as the renal protection is concerned, if you look at all the CVOT trials of all the glipozins, they have clearly shown that they reduce the renal pre-specified renal endpoint by about 40 to 50%. So that's a very good options in this scenario as far as renal protection is concerned. Also, you need to reduce the weight to keep the SGOT or SGPT down. So there has been a number of studies where empagliflozin has been shown that reduces the SGOT, SGPT level in non-alcoholic steatohepatitis. So what are the options for this patient? So I already discussed about the goal of achieving A1c, reducing the weight, reducing the blood pressure, the renal protection, reducing SGOT, SGPT, and should be achieved in a very convenient manner so that patient would be compliant to continue the medications. So options are that to having the glycemic control, we need to increase the dose of insulin so we can achieve the HbA1c of less than 7%. But the problem is the patient is already on about 100 unit of insulin per day. So and the patient is progressively gaining weight. So if you increase the dose of insulin, that may further increase the body weight of the patient, that also have some deteriorating effect on the SGOT, SGPT, as well as on the cardiac function. So we need to add an anti-diabetic which would achieve all these goals. So what is that anti-diabetic which would achieve all these goals? I think if in this scenario, I think instead of increasing the dose of insulin, the best way is to stop vildagliptin and metformin combination. As you know, vildagliptin is a weight neutral agent. So you need to add another medication. So probably we'll continue with the same dose of insulin at present. Will cut and will increase. I will increase the dose of metformin to 1 gram twice daily. We all know the beneficial effect of metformin. There is no doubt about that. So I would increase the dose of metformin to 1 gram twice daily. And the second thing is I would add a combination of empagliflozin and linagliptin combination so that we get the advantage of both these good medications, both DP4 inhibitor as well SGLT2 inhibitor. So these are very good anti-diabetic as far as the HbA1c is control is concerned, as well as the body weight reduction is controlled with the SGLT2 inhibitor. However, linagliptin has been found to be body weight neutral. And also there has been lots of studies shown that as like linagliptin, the CVOT trial clearly shows that reduces both Carmelina and Carolina studies that reduces the progression of the nephropathy. So if you combine SGLT2 and linagliptin, so it's far more giving protection to the kidney, and SGLT2 reducing the body weight, reducing the systolic blood pressure. So many of these goals, once the body weight is reduced, then SGOT, SGPT would also come down. So many of these goals would be achieved if you use empagliflozin and linagliptin combination, and this can be achieved only once a day dose. So patient would gradually, once the glycemic control improves with empagliflozin and linagliptin combination, as the glycemic glucotoxicity reduces, there will be reduction in the insulin resistance also, and gradually this patient the blood sugar became normal with the after starting empagliflozin linagliptin combination along with metformin. So after a few months, about 2 months, 3 months later, I found that the insulin requirement also is going down because of the reduction in the glucose toxicity, reduction in the insulin resistance. So from 100 unit of insulin, he was about on 70 unit of insulin per day after 2 months of treatment with empagliflozin and linagliptin. So just to summarize regarding this patient with type 2 diabetes, obese, hypertensive, dyslipidemic, and on high dose of insulin with deteriorating renal function. So this patient was managed with continuing the insulin and increase the dose of metformin and adding just a single dose of empagliflozin linagliptin combination, which would address all the goals we have kept for this patient: glycemic control, reduction in the systolic blood pressure, reduction in the body weight, and renal protection, reduction in the HUT and SGPT. So this is probably the scenario of adding one of the scenario where we can add empagliflozin linagliptin to already existing insulin therapy along with metformin. As you know that DP4 inhibit the postprandial blood sugar by reducing the glucagon level, and SGLT2, they do have beta cell independent action. So maybe patient is diabetic for 20 years, you expect this medication to work along with metformin. So this is a very good example of how you use empagliflozin and linagliptin combination in a long-standing diabetes. Thank you.